why was there a need for new guidelines?
So we had European guidelines written in 2017, but a lot has happened since then. We have now a number of novel agents that have become available, both initially at relapse, I'm talking about BTK inhibitors, that are now also entering first-line treatment. And we also have a number of agents available at relapse, for instance, CAR T-cell therapy, important, BCL2 inhibitors, and also novel BTK inhibitors. So there was definitely a need for an update.
Welcome to EHA Unplugged, the official podcast channel from the European Hematology Association, EHA. I am your host, Isabel Olivera. Today we're joined by Professor Prof Jerkeman, who is a professor of oncology at Lund University in Sweden. Professor Jerkeman has been instrumental on shaping the recent EHA clinical guidelines on mantle cell lymphoma, MCL. So we are delighted to have you with us today to discuss these guidelines and what they mean for clinicians and MCL patients across Europe and beyond. So thank you very much for being with us today.
Thank you for hosting me.
So to start off, could you explain what are the main clinical features of MCL?
Yes, mantle cell lymphoma is something in between the indolent and aggressive lymphomas. It's a B-cell malignancy, and it can sometimes be very indolent and be managed by a watch and wait approach, actually, like other indolent lymphomas. Perhaps around 20% or so can be managed like that. But it can also be a very aggressive disease that require very intensive therapy, and especially at relapse, it can be very aggressive. And it presents usually as lymphadenopathy, but often also with lymphocytosis, and bone marrow involvement is almost mandatory, occurs in about 90% of patients. Also gastrointestinal involvement is characteristic for mantle cell lymphoma.
How are patients stratified? You were saying that you can have from indolent lymphoma to a very aggressive form. So what are the main challenges when you have a newly diagnosed MCL? What are the risk factors to take into account?
Yes, traditionally we have looked at age, because the previous standard treatment for younger patients, at least up to 65 years, has been treatment involving high-dose cytarabine as induction, and also consolidation with high-dose chemotherapy and autologous stem cell support. Treatment has been divided according to tolerability for autologous stem cell transplant. So that has been an important point. But we have now learned that biological risk factors may be more important, and that includes histological subtype. There are a proportion of patients present with blastoid or pleomorphic histology, which is a high-risk factor. Also, proliferation is important. PI67 above 30% is a biological risk factor. And perhaps the most important one that has been recognized is the presence of TP53 mutations. It means that the patient will have a very short remission with standard chemoimmunotherapy.
So in first line, what was the standard of care before in first line, and what is it today?
Yes, so as I mentioned, younger patients, the standard of treatment was alternating anthracycline-based therapy like R-CHOP, alternating with a high-dose cytarabine-based regimen that could be cytarabine only or DHAP, and then consolidation with autologous stem cell transplant. We also learned that maintenance with rituximab prolongs overall survival for this subgroup. So that was the standard for younger patients. For elderly patients that are not eligible for autologous stem cell transplant, the standard has been more lower intense chemotherapy like R-bendamustine, has been the most frequently used. R-CHOP has been used, and also VR-CAP, which is R-CHOP with bortezomib instead of vincristine, that has been shown to improve survival compared to R-CHOP. But for elderly patients, the most common has been R-BEN, I would say.
And what is it now? What are the recommendations in the new guidelines?
Yes, for younger patients, a major step forward has been the results of the huge European triangle trial, which has been meant paradigm shift in the treatment of mantle cell lymphoma. In this trial, the standard treatment that I mentioned with high-dose cytarabine and autologous stem cell transplant was compared to 2 experimental arms. In one arm, ibrutinib was added to R-CHOP in induction and also as maintenance for 2 years. And in the third arm, the second experimental arm, ibrutinib was added, but autologous stem cell transplant was removed. And the results show that the addition of ibrutinib to induction and maintenance improves overall survival. We all know that. And there is no difference if we give autologous stem cell transplant or not. So the standard treatment now is R-CHOP plus ibrutinib, alternating with DHAP or DHAX, which is oxaliplatin instead of cisplatin, and then maintenance with ibrutinib and rituximab. So no more autologous stem cell transplant. So that is the most important change. So that will definitely reduce toxicity for patients, and the efficacy is also much better. So with an improvement in overall survival. So that's the new standard treatment. And this, as we remove autologous stem cell transplant, we can give this type of regimen to also patients that are above 65 years, perhaps around 70 years. So that's the new treatment for that population. And then the majority of patients with mantle cell lymphoma, they are elderly. The median age is about 71 years in population-based studies. A large proportions will not tolerate this regimen, and they, for that population, are bendamustine still an option, I would say, and VCAP as mentioned. But there has also been studies that add a BTK inhibitor to bendamustine to see if that improves outcome. And it has been shown to improve progression-free survival, definitely by adding ibrutinib or acalabrutinib to bendamustine. So that can also be a standard option for some patients, but it also increases the toxicity of this regimen. But that's another standard option. And there are also now trials showing that only a BTK inhibitor in combination with a CD20 antibody like ibrutinib rituximab is at least equal in efficacy to bendamustine. So that may also be an option for elderly patients.
And how do you choose among all these options that are suggested in the guideline?
Yes, for younger patients, I think it's easy because we have a very good regimen according to the triangle trial. But for elderly patients, it's difficult, I think, to choose the right treatment, because an important regimen at relapse is CAR T-cell therapy. And we know that bendamustine impairs T-cell activity, both the number of T-cells and the activity of T-cells. So in patients that have a high risk of relapse and may need CAR T-cell therapy, we'd like to avoid bendamustine. Then we look at biological risk factors. So patients without biological risk factors, I would prefer bendamustine or ibrutinib, if that is available, if that is possible to use, or rituximab combined with another BTK inhibitor. But for high-risk patients, it's harder. We would like to avoid bendamustine. So in that situation, I think VCAP could be an option for elderly patients, avoiding bendamustine.
So as you mentioned, now there is an option of using BTKI in first line in old patients and frail patients. So now that BTKIs are moving into first line, what are the recommendations for second line?
Yes, it depends on the situation also here. Because now in the triangle regimen, there is a specified limited duration of maintenance with BTK inhibitors. So patients who have received ibrutinib for 2 years, according to the triangle regimen, and stop, and then a year after have a relapse, they can be restarted on a BTK inhibitor again. So that is one situation. Perhaps more commonly, the relapse occurs during the treatment with the BTK inhibitor. And then the disease is refractory to BTK inhibitors, and we need something else. And then we have a couple of options. We have CAR T-cell. Brexucell is the one that is approved in Europe. So that is one standard option in this situation, and the one with perhaps the highest activity as well. But we also have now available in Europe pirtobrutinib, which is a non-covalent BTK inhibitor that has activity also in patients that are refractory to covalent BTK inhibitors. So that is another option. And it can also be used as a bridge to CAR T-cell treatment. But there are also other possibilities like chemoimmunotherapy. Our BAC, for instance, that is rituximab, bendamustine, and cytarabine is an option, and our GEMOX can be an option as well. And there are also other agents that are under development, like other BCL2 inhibitors and bispecific antibodies.
So all of these novel therapies are not the same price tag. How widely are they available? Especially, obviously, CAR T, but some of the others are also very expensive. Are they used widely in Europe?
Yes, I think they are available in most European countries now, Brexucell, but not in every country. But in most countries they are available. They are considered cost-effective and are reimbursed, but not everywhere.
So this doesn't play a role or a big role in choosing which will be the second line, not the price tag. It will be really the clinical situation.
Yes, I think in most cases, yes. But the problem is that the CAR T-cell therapy in mantle cell lymphoma is not curative as it is in diffuse large B-cell lymphoma. So we don't see a plateau in progression-free survival as clearly, at least, as in diffuse large B-cell lymphoma.
So which other therapies can we expect in the future? What is in the pipeline that you were referring to?
Yes, there is, for instance, sonrotoclax, that is another BCL2 inhibitor that is active in relapsed mantle cell lymphoma also after BTK failure, and also CD20, CD3 bispecific antibodies like glofitamab and epcoritamab are very active in this situation. We will also probably see other CAR T-cell products like Lisocell is approved in the US, for instance, for relapsed mantle cell lymphoma and has a lower frequency of CNS toxicity compared to Brexucell. So it's also an attractive option.
So how do you feel these new guidelines fit in the daily clinical practice?
Well, now I think the guidelines are in line with the current situation. And what is also very positive, I think, that these can be updated more frequently than we hope that these will be updated yearly at least, so we don't have to rely on obsolete guidelines that cannot be used. So I think we're in a much better situation now than we were before. So
is there anything else that you would like to add for the audience that I haven't asked?
Radiotherapy is also a very active treatment in mantle cell lymphoma. That's something we may forgot. It's easier for oncologists to use radiotherapy perhaps than for hematologists. Mantle cell lymphoma is extremely sensitive to radiotherapy, so that's a good option also at relapse and also as a bridge to CAR T-cell therapy. Another possible treatment is also allogeneic stem cell transplant, and that was used more frequently before, less frequently when we have access to CAR T-cell therapy. Limitation is also age, that many patients are elderly with mantle cell lymphoma, but there are still, I think, a population that may benefit from allotransplant. At least after CAR T-cell therapy, it may be still the only curative treatment for mantle cell lymphoma. But I think mantle cell lymphoma has not been considered curable, but that is something that I think and hope will change, that this will be a curable disease. I think we will be able to see that.
With which agents? So you say that CAR T therapy is not doing it, so SCT, it's an option, but less used now. And what could be a curative option?
I think we cure patients already now with the more intensive treatment, and the triangle regimen, I think, will be curative in a higher proportion of patients. That's my hope, at least, because it's clearly improves overall survival. And I think even with the previous standard treatment, we have seen that after 20 years, 1/4 of the patients are without relapse and remission. They may be cured. With a new regimen that is more effective, I expect we see an even higher proportion that will be have a long-term remission.
Which is excellent news. So if you want the audience to remember just one thing from the guidelines or this podcast, what would it be?
Well, the treatment, for at least for younger patients with mantle cell lymphoma, has undergone a significant change now during the last couple of years that will probably have a major impact on outcome and possibly be a curative treatment for mantle cell.
So pay attention to these guidelines and use the new treatments and the recommendations that you have made. So thank you very much for sharing your experience with us.
Thank you so much.
Thank you to the audience for listening. And if you enjoyed this episode, please like it and subscribe to our channel. Stay tuned for more episodes of EHA Unplugged.